Hello students, today I am going to talk about a topic from the cardiovascular system, cardiac arrhythmia, a very important topic. Here I will discuss about the what is the cardiac arrhythmia, what are the types of cardiac arrhythmias. Also we will discuss something about the normal rhythm of the heart, and then we will discuss about the drugs which can be used in this medical condition. So let us see what the cardiac arrhythmias and the drugs are there. If we talk about the mechanism of arrhythmias, before going into the mechanism of arrhythmias, we also need to brush up our understanding for the normal rhythm of the heart, that I will discuss in a short while. And when we talk about the arrhythmias, so arrhythmia word itself shows that something which is not in the rhythm. So when we are talking about the cardiac arrhythmias, means cardiac rhythm. What does it mean, the cardiac rhythm? The cardiac functions, right? Especially here, if we talk about the cardiac electrophysiological functions, for example, how the first electrical impulse generate in the SN node, and from the SN node this impulse carried forward to the left atria, and from there it comes to the AV node, and from the AV node it goes down to the what called the bundle of hairs, then the bundle branches, and then Purkinje fibers, and then this way it reaches to the all the heart wall. So what actually happens for this for the generation of the beat as well as for the conduction of the beat, what heart needs? Heart needs one common rhythm, right? One normal rhythm. And whenever any of these things not happens rightly, the heart loses its normal rhythm, and then it goes arrhythmic. Now, in this case, the two conditions are happening: either the rhythm goes slow or the rhythm goes fast. In both the condition, the heart is going to be arrhythmic. So, if you consider this, the normal heart beat is around 60 to 100. Suppose that you take this normal range 60 to 100. So, whenever the the heart rate goes below to the 60, then also it is abnormal rhythm. If it goes above to the 100, then also it is an abnormal rhythm. So when it goes below to the 60, we call it as the heart goes slow. So when heart goes slow than the normal, it is also arrhythmic. So we call it as one special term, call it as bradyarrhythmic, or you can call it as in bradycardia. In the other case, if it goes above to the 100, so it means the heart is little faster than the normal. So in that case, we call it as another term called tachyarrhythmia, or call it as tachycardia. So like that, the two terms are here, bradyarrhythmias and tachyarrhythmias. Here I would like to show you this picture to make you clear that what does it look like. If you see the first one, this is your SN node here, and this is the AV node here. Whenever the impulse generates from the SN node, it passes to the right atria here, as well as it uses three tracts to reach to the AV node, right? These anterior, middle, and posterior internodal tract. These tracts are between the two nodes, SA node and AV node, right? So that impulses which are generated in the SA node, these tracts bring them to the AV node, as well as through the right atria, the impulse also come back to the AV node here. Now once the impulses reach to AV node, the AV node movement of AV node, or the conduction velocity in the AV node, is quite slower, right? So you can understand in this way, from SN node to AV node, it comes with a little moderate speed or velocity, but from AV node to bundle of his, this area is here bundle of his, so it comes with a very slow pace, right? But from bundle of his to the bundle branches here and to the Purkinje fibers is very fast. So you can see the velocity is also changed, and this is what the heart follows. That's what it maintains its normal rhythm, right? But if any of the thing has changed, then the rhythm will get disturbed, right? So you can understand this point very well here, that first requirement is that impulse should generate from the SA node. It must conduct through the AV node. And third thing is that while it's generating and conducting, it should follow one constant what called the velocity. Okay, so if it is following these three conditions, it will go with a normal rhythm. But whenever these conditions get changes, the normal rhythm not follows. So you can see here by this way, from SA node to AV node, then AV node to bundle of phase, then divided to bundle branches, and then it goes to the Purkinje fibers, and then it circulates to hold the heart wall. So this way here this whole system, the whole rhythm maintained. So whenever this rhythm goes beyond the conditions of normal, either slower or faster, it will cause the arrhythmic conditions. So arrhythmia, bradyarrhythmia, what I told you, that's going slower than the normal. There may be one reason, that it is maybe failure of impulse generation. So if impulse are not generated, then of course the further beats or further contraction cycles won't be received by the heart, and then it will be acting slow, as well as the failure of the excitatory wavefront conduct from the atrium to the ventricle through the atrioventricular node, means the wave of the impulses which has been started from the atrium and goes to the ventricle, if that fails to start from there, so that is may also cause the bradycardia. So one thing we can summarize here, that if the normal sequence of impulse initiation and propagation fails or disturbs, it causes arrhythmia. If it goes slow, bradyarrhythmia. And another condition is that failure of impulses to propagate normally from atrium to ventricle. So now if it is not reaching from atria to ventricle, and it drops its beat, so maybe that condition we call it as an heart block. Okay, and usually that reflects an abnormality in either the AV node or the his Purkinje system. So this problem what we are talking here, why it's happening, maybe because the problem somewhere in the AV node or somewhere in the his Purkinje system. So that because the AV node and his Purkinje system are the main component for the conduction system, while SA node is the main responsibility for SA node is to generate the impulse. So it generated, pass it on to the AV node. Now it's AV node's responsibility to conduct it properly. So as I told you, to understand the cardiac arrhythmia, we have to understand the normal rhythm. And here I have brought this one animated diagram for you, and this diagram is wonderful, created by the source I have given there. It gives you great information about the cardiac cycle, as well as lot many other information, right? So you can find it out here. The left side you can see the heart, how the valves are opening, how the blood is flowing, how the contraction and relaxation mechanisms are happening. And the same way, when the one contraction and one relaxation mechanism happen, one systole and one diastole, we call it as an one cardiac cycle. So in that one cardiac cycle, how the impulse generated, how the impulse conducted, and then again a new impulse generated and conducted. So like that, one cycle completes by one generation of the impulse. So here if you see that the diagram which has been shown here, you can find at the top ECG, or you can correlate how the heart moves, or how the cycle moves, and what is the change, what are the changes happening in the what called the ECG as well. So by this, when this green line is actually the one cycle. When green line reaches from one place to other, it completes one cycle. So you can say, once the green line moving from one side to other side, what are the changes are happening are written here. You can see, by moving this line, you can read about the aortic pressure. You can understand the atrial pressure, you can understand the ventricular pressure, you can understand the ventricular volume as well. Along with that, you can find out the S1 and S2 sounds, which we call it as a heart sound, that also you can understand by this. You can also observe at what point of time the semilunar valves are opening, at what time the semilunar valves are closed, right? You can understand the atrial diastole, atrial systole, and then ventricular diastole, and then again then what, and the same time when the atrial systole ends, actually the S1 sound creates, right? So like all these things already you have studied during the cardiac physiology, but it's very important to understand here, and this diagram will correlate everything together, and it will help you out to understand the normal cardiac rhythm, right? So this cycle can be followed uh, normally when the electrical impulse generation and conduction happens normally, right? So that's what, everything depends on each other. Whenever it goes normal, we call it as an rhythmic heart cycle, right? So whenever it goes abnormal, then we call it as arrhythmic heart cycle, right? So I hope you can take a little more time on this particular diagram, and you can get lot other answers through this one. Here one flow chart is there. This is showing some active arrhythmic mechanisms. I'll just give you a little bit about it. If you see, the active arrhythmic mechanisms can be here they have categorized in two categories. One is abnormal impulse formation. If the impulse formations are abnormal, then they will create certain arrhythmic conditions. If the abnormal impulse formation happens, then it can be of two categories. Maybe the impulse formation is having a triggered activity, or maybe having the increased automaticity. So we'll take first one, the triggered activity. Then triggered activity, if it is there, it will bring the another condition called EAD, early after depolarization. I will explain you later what the EAD is. And then it will bring the another condition called delayed after depolarization, DAD. Same way, enhanced automaticity brings the enhanced pacemaker activity. Also parasystole it can also bring. Second active arrhythmic mechanism is reinterrent, where the impulses are re-entering into the same path again and again. So that also I will explain you later. And it also has various type of re-entry, right? So that we will discuss later. So these abnormalities means the abnormal cardiac rhythm may be brought by various abnormalities, right? So these abnormalities may be they caused by some drugs, or maybe some anatomical conditions, like some structural changes in the heart. But if there are some structural changes has brought the abnormalities, then permanent cardiac pacings are required. We have to create certain kind of devices which can produce permanent cardiac pacing. And the condition where the rhythm goes on the higher side, right? The heartbeat goes on the higher side, then we call it as an tachyarrhythmias. So in both the condition, we have to treat them by considering serious, and there are anti-arrhythmic drugs which can do that. Here I would like to make it one point clear that as I told you, that if you consider a one range of the normal heartbeat, suppose that 60 to 100 you are considering as a normal heart rate, and it goes below to the 60, then we call it as in the heart rhythm is slow, and we call it as an bradyarrhythmias. And it goes above 100, then we call it as an tachyarrhythmias, right? The heart rhythm is on faster side. So fast abnormal rhythm, and the bradyarrhythmia is a slow abnormal rhythm, right? Both are abnormal, but one is fast and another is slow. But there are one more another conditions also. When the heartbeat goes more than 150, or it goes up to 200, right? Or 250. So more than 150 to 250, in that range, then that condition has another term called as paroxysmal ventricular tachycardia, PSVT, or that is also called as paroxysmal tachyarrhythmic. Actually, we call it as paroxysmal tachyarrhythmia, that particular condition. But when it happens in ventricle, we call it as an paroxysmal ventricular tachyarrhythmia. There are another serious conditions when it goes more than 250, right? Maybe up to 350. Then that condition called as flutter, F-L-U-T-T-E-R, flutter. That's called cardiac flutter. Okay, and there are one more. There is one more unfortunate condition which we call it as more than 350 times per minute. The beat goes, then we call it as an fibrillation, right? Now, as when these conditions are happening in the particular location in the heart, then we give the name accordingly. If the flutter condition comes in atria, we call it as atrial flutter, right? When it comes to the ventricle, we call it as ventricular flutter. Same way, fibrillation, we call it as an atrial fibrillation. Or if it happens in ventricle, we call it as ventricular fibrillation, right? So these terminologies are given in this case, and same thing happens in case of bradyarrhythmic as well. If it goes less than 60 up to 40, it called as mild bradycardia. Even less than 40 up to 20, then called moderate one. And if it is even lower than 20, more unfortunate condition, then we call it as severe bradyarrhythmias. These all either bradyarrhythmias are there, or flutters are there, or fibrillations are there. They all are serious medical conditions. So these abnormal rhythms which are coming, if they are coming because they are happening, suppose that one arrhythmic condition happens because of the SA node. Okay, so we call it as sinus arrhythmia, because it happens because of the SA node, so we call it as a sinus arrhythmia. If it is happening because of some anatomical changes in the atrial region or the atrial tissues, we call it as atrial arrhythmia, right? Same way, it changes. Suppose that this condition is happening in ventricle, so we means the arrhythmia happens because of some changes in ventricle. We call this as ventricular arrhythmias. One more condition is there when it is happening in between, that means in some junctional area or in the nodal area, we call it as a junctional arrhythmia or called nodal arrhythmia. So these are also the conditions, terminologies we are using. Okay, now I'll move on to the main mechanisms of arrhythmia. Here we have three main mechanisms. One is enhanced automaticity, triggered automaticity, and third is re-entry. Before understanding the enhanced automaticity or the triggered automaticity, we have to understand again, means I just want to brush you up, the impulse generation in the cardiac cells, right? So you know very well, you just close your eyes and recall the, you know, action potential generation in the nervous system, what you have already studied. So in the nervous system, how the action potential generates, right? So here also similar kind of things followed, slight changes that I will tell you. So here you can see the sodium enters, sodium channel opens, and the depolarization starts from here, and which we denote as a phase 0, and sodium keeps on coming in, and it goes up to threshold, and in the threshold the impulse generated. When impulse generated, the more channels are opening and more sodium channels are coming, more sodiums are coming in, and the depolarization happens. Okay, and you can see that it reaches to the phase 1. After that, the sodium channel start closing, but the same time when sodium channel closes, potassium channel starts opening, but the potassium channel opens and the potassium outflow starts, means potassium efflux starts going out to the cardiac, from the cardiac cell it starts, but same time the calcium channel opens and calcium also starts coming in. That's why the net change in the upper portion in the phase 1 and the phase 2 not happens much. So one kind of plateau condition observed, which is not there in case of the nerve action potential. You can see the nerve action potential, if it goes like this, it comes like this down. Okay, it goes like this in the nerve action potential here, or it comes like this, right? But here you see in the cardiac action potential, here you can find a little broader region, right? This broader region here, what you are observing here, the broader region, this is happening because here you can see the calcium channels open. Because of the calcium channel opens, the process here, the process of repolarization, which has to come down like this, it delayed little bit and it comes like this. So what happens, this area is got little flatter, right, which we call it as plateau phase, right? So this is got little flatter and is given little more time. So the actually depolarization has maintained there on the top for little more while, and that's what afterwards when the potassium starts moving out faster, you can see here, that is the phase 3 condition. Then it recovers its membrane potential, resting membrane, which maintains its resting membrane potential here, and then it comes down, right? So and after that, when it reaches to here, it will go for the refractory period, or it will take some time here where no depolarization happens and then afterwards it will again start a new cycle. So this way in the cardiac cells the action potential generates. So we'll see the first one, which is called the enhanced automaticity. So enhanced automaticity, actually I tell you, uh, automaticity meaning itself that the cardiac muscles or cardiac cells are able to produce the depolarization and they can spontaneously produce the depolarization, and they continue producing it. So that condition is making them, automatic cells. So they are having that automaticity in them. They can generate their own impulse by that. So here what happens, there are the role of certain chemicals or the neurotransmitters which are playing the main role here. If you see the role of epinephrine, when it binds with the beta 1 cardiac receptor, it increases the level of calcium intracellularly. You can say the calcium load has been increased. Because of the calcium load increases, the action potential triggers, right, or enhances. So when that action potential enhances, it goes for the one tachyarrhythmia condition, right? So here what happens, enhanced automaticity may occur in sinus, AV nodes, and in the His-Purkinje system. And which are the factors responsible for this? Beta adrenergic stimulation, hypokalemic conditions, or a mechanical stretch. So these all conditions increases the phase 4 slope, right? I have already shown you what are the phase 0, 1, 2, 3 and 4, and so accelerates pacemaker rate. Okay. So here they are increasing the automaticity, means they once the repolarization starts or repolarization happens, the impulse generation and conduction goes slowed down. Okay, because for impulse production, impulse generation, you need a depolarization. And what happens in case of beta adrenergic stimulation? It stimulates it, right, and the produces the hypokalemic condition as well. So what happens ultimately, the depolarization states prolongs little more, so the automaticity will go for more time, right? It will enhanced it now. Whereas if you see the other neurotransmitter which has the opposite effect of it, whereas acetylcholine reduces pacemaker rate both by decreasing phase 4 slope and by hyperpolarization, making the maximum diastolic potential more negative. So like that, these drugs are changing the response of these tissues. In addition, automatic behavior may occur in sites that ordinarily lack spontaneous pacemaker activity. Now this is another condition. What happens, because in the heart physiology it is already predefined that which are the tissues uh, who have a responsibility for generating the impulses and conducting the impulses. So that is fixed, and the pathway is also fixed for the movement of the impulses. But what happens here, sometime the tissues which are not supposed to take part in generation of impulses, they start taking part in generation of impulses. So then suddenly the normal system get disturbs, right? For example, AV node are not supposed to produce the impulses, but if it start producing impulses, or maybe the bundle of His, which bundle of His has the job just to conduct the impulse which has been received by AV node, but if it start producing it, then they become the reasons behind the arrhythmic conditions. It is also possible for tissues to serve as an ectopic focus, and these areas which are not, they should not produce the impulses, but they are producing the impulses right now. In these tissues or these areas, we call it as an ectopic foci, right? So these conditions called as ectopic foci. So this is the one condition. What happens in the case of the enhanced automaticity because of these neurotransmitters. Now we talk about the second condition of the arrhythmia, second mechanism, which is called after depolarizations and triggered automaticity. So triggered automaticity, what is happening here? Under some pathophysiological conditions, a normal cardiac action potential may be interrupted or followed by an abnormal depolarization. So what happens? You have just seen that what is the normal condition. The depolarization happens, the sodium channel opens and depolarization happens. Then it reaches to the peak of its section potentials generation, and then sodium channel starts closing down, potassium channel opens, same time calcium channel opens, and then the repolarization gains, and then that reaches to the phase 4. So likewise, this is a normal mechanism, right? The normal action potential generation. But now what happens if this goes modified? This goes modified by some condition, right? Then what happens? The triggered automaticity is a result. You can see here is the abnormal depolarization reaches threshold. Suppose that you imagine one condition where the depolarization happens, but this depolarization is an abnormal depolarization, right? So usually abnormal depolarization dies before it reaches to the threshold, right? But suppose in the condition when this abnormal depolarization reaches to the threshold, so what will happen? It will generate the impulses at that time when it was not needed, or it should not generate. So when this is an extra impulse generated in the wrong timing, which will disturb the heart's conduction system, right? So that what it propagates and create the abnormal rhythm. These abnormal secondary upstrokes, we call it as an abnormal secondary upstroke, means it should not happen now, but it happened. So we give it the name as a secondary, means second time it again generated. So secondary upstroke happened. Occurs only after an initial normal or triggering upstroke, and so are termed triggered rhythm. And because they came in between, right? So they have given an extra impulse to the heart, and that will go an extra beat to the heart. You can say the heart will go a little faster. So that is the triggered rhythm. They brought into the triggered rhythm. Now, very important points here, two very important points to understand. These triggered rhythms or triggered automaticity brings two very important conditions. One is called as the EAD, another one is called as the DAD, right? First, I'll tell you EAD, the B, the second one. Early after depolarization, right? Early after depolarization. So first term you understand after depolarization. So you can see here already one depolarization happened. Okay, so it means I'm talking about the condition happening here. It means what? It means depolarization already happened. Okay, depolarization already happened. So after this depolarization, so here it means we are talking about the after first depolarization. Okay, then a term comes early. When we say early, it means what? After the first depolarization, the second depolarization came early. Okay, so when the second depolarization came early, we call it as an early after depolarization. Okay, so what is happening? You can see here it's supposed to go down like it was going, but before it completes the phase 3, before it completes the phase 3, here extra impulse generated. You see here extra impulse generated. I hope you understood. So this extra impulse which has been generated here, it it has not allowed the phase 3 to complete. The repolarization has not completed. So before the repolarization completes and it goes to refractory period, it has started a new cycle. So it goes very fast. Okay, in between. Second condition, this is one condition. Second condition is where the it's called delayed after depolarization. Same word here, like after the depolarization, The second, another depolarization came, which is delayed. Now you don't think it is delayed than the normal. No, it is delayed than the early, right? You compare these two here. So it is delayed compared to this, right? Not the normal. It's not delayed than the normal, but it is delayed than the early. Okay. So here the early came from here itself, while it came after the completion of the phase 3 or the repolarization, and before completing its refractory period it generated, right? So both are actually the faster one, but comparatively one is slower and one is faster. So DAD and EAD. So these are the two conditions created. And why this happens? This can happen by any reason, right? Maybe some other tissue has started generating the impulse, okay, or maybe some extra calcium load has been created, okay, maybe some inflammatory conditions are there. So by any reason this DAD and EAD can be generated. So here also just similar thing you can understand: 0 phase, 1 phase, 2, 3 and the 4 phase, right? Just similar thing. Two major forms of triggered rhythm are recognized. Now when we talk about the triggered automaticity, there are two forms have been recognized. In the first case, under conditions of intracellular calcium overload. So one condition is when the calcium is overloaded, right? In conditions of myocardial ischemia, adrenergic stress, digitalis intoxication, heart failure, right? The calcium overload. A normal action potential may be followed by a delayed after depolarization. So what is happening? Normal action potential generate first. It is started as a normal action potential, but once it is reaching to its end, the delayed after depolarization happen, right? If this after depolarization reaches threshold, a secondary triggered beat or beats may occur. So you understand this point here very well, that suppose that this impulse which has been, or action potential which has been generated here, if it initiates and dies, means it not reaches to the threshold. If it not reaches to threshold, it will die. It won't affect the normal functioning. But if it reaches to threshold, so what is actually happening here? Here you see, if it reaches to threshold, it will generate the impulse, right? That's the problem. So if this after depolarization reaches the threshold, a secondary triggered beat or beats may occur. In this second type of triggered activity, the key abnormality is marked prolongation of the cardiac action potential. In the second condition, what happens? The action potential which has been generated is prolonged, right? It's for a little more longer period, right? What you have seen in the case of delayed. When this occurs, phase 3 repolarization may be interrupted by an early after depolarization. EADs are induced much more. Here I told you the prolongs the cardiac action potential, means before repolarization completed, another depolarization came. So like that, the depolarization has been continued, which we call it as an EAD. So EAD are induced much more readily in Purkinje cells and in mid myocardial cells than in epicardial or endocardial cells. It is telling the priority where it happens maximum. So EDs can be found maximum happens in the Purkinje cells, then mid myocardial cells, and compared to the epicardial and endocardial cells. When cardiac repolarization is markedly prolonged, see, repolarization markedly prolonged, polymorphic ventricular tachycardia with a long QT interval known as torsade de Pontes syndrome may occur. So this is one very known arrhythmic syndrome, which we call it as entorse de Pontes, happens. This arrhythmia is thought to be caused by EADs, which I have already discussed. Now we'll reach to the third mechanism of arrhythmia, which is being generally caused by the changes in the structure of the heart, right? So they are usually structurally oriented, right? Re-entry, which we call it as anatomical changes. So what is happening here? Here also two conditions are there. One condition where anatomical changes have forced the conduction system to go abnormal, because the anatomical changes, what happens, so the different tissues are having the different automaticity, right? And these difference in automaticity will brings the difference in the velocity as well, and then their timings get disturbs. I will tell you by diagram how it's happening. And second condition is that there also a slight anatomical changes are there, but the re-entry happens because of the functional change there, which we call it as a circus movement also, right? Let's see what is this. Re-entry can occur when impulses propagates by more than one pathway. So now if there are two pathways, now question is from where these two pathways came. Right? Now, in normal heart there are no two pathways, there is a one single pathway and strictly it has to follow. But because here one already explained you that there are anatomical conditions, there are some anatomical changes, right? So because of the change in structure, there are alternative pathways have been developed, which we call it as an accessory pathway. And these pathways have heterogeneous electrophysiological properties, right? As I told you, they have different physiological properties, okay? Means different ability of impulse generation, different ability of impulse conduction, different velocity rates and all. Patients with here I am taking one example of the patient of Wolff Parkinson White syndrome, WPW. Right, this is the one condition. In this, what happens? Have accessory connections between the atrium and ventricle. Means it is a very rare condition, but it happens. So those those who are the patient of WPW, they have in their heart they have alternative pathways, and these pathways are connecting the atria and ventricle. With each sinus node depolarization, impulses can excite the ventricle via the normal structure or the accessory pathway. So now in these conditions, whenever the normal depolarization happens, so as I told you, the normally when depolarization happens, it goes to the AV node. From there, the bundle of phase, then Purkinje fibers. That way, it reaches to the ventricle, right? So here also happening the same. Impulse generates, or you can say depolarization happens, and it reaches to the ventricle. But sometime it not goes by the AV node, while it goes by the accessory pathway, right? However, the electrophysiological properties of the AV node and accessory pathways are different, as I told you. Sorry. Accessory pathway usually consists of fast response tissues. Now, this is a very important point to understand. AV nodes, as I told you from beginning itself, the AV nodes are conducting very slow, right? Their velocity is very slow. While this new pathway, which is an accessory pathway, they have change or a difference of velocity compared to AV node. They are much faster than the AV node. Now thus with a premature atrial beat, now if there is a premature atrial beat happens, right? So the impulse which is being generated is a very weak impulse, right? So conduction may fail in the accessory pathway. So what happens, because it is so slow and the accessory pathway conduction system is very fast, so this premature impulse won't be taken up by the accessory pathway, but because AV node is slower, it takes that pathway, that impulse, and slowly it conducts, okay, in the AV node and then through the His-Purkinje system. So from AV node it goes to His-Purkinje system. There the propagating impulses may encounter the ventricular end of the accessory pathway when it is no longer refractory. So what is happening here? When it goes down to the Purkinje fibers, it will connect with the accessory pathway, right? Because it goes very slow. So it goes and connect with the accessory pathway. Now accessory pathways are not in the refractory mode, right? They are not in the refractory mode. So once it goes into the connects with the what called the accessory pathway, through the accessory pathway is goes back to the atrium. From the atrium again it comes to the AV node, okay, and then from AV node again it goes to the accessory pathway. So it starts entering again and again to the same pathway, right, and it's doing a kind of circus movement there. The likelihood that the accessory pathway is no longer refractory increases and AV nodal conduction slows. When the impulse re-enters the atrium, it then can re-enter the ventricle via the AV node, re-enter the atrium via the accessory pathway, and so on, as I told you. Here you can understand here the premature beat is being generated from here, not carried forward. This is an accessory pathway, right? Not carried forward by the accessory pathway, but taken up by, this is a AV node, but taken up by the AV node and slowly it moves down, okay. When it moves down, it finds this accessory pathway, and through accessory pathway it goes back, and this through accessory pathway it reaches to the atrium and AV node, right. From here it reaches to the AV node, you can see from here it reaches to the AV node, and again it comes down, right, again it connects with the accessory pathway and again it goes there. So it starts moving like this, okay. So again and again it entering into this same pathway. I hope you understood what this means. So re-entry of this type, referred as the AV re-entrant tachycardia, is determined by three main points. One, the presence of an anatomical defined circuit. Second, heterogeneity in refractoriness among regions of the circuit, means they have different electrophysiological property. Slow conduction in one part of the circuit. Similar anatomical defined re-entry commonly occurs in the region of the AV node and in the atrium, which brings the atrial flutter. The term paroxysmal supraventricular tachycardia includes both AV re-entry and AV nodal re-entry. This is also important point when doctor says there is a PSVT. So it means that both the conditions are there. Okay, so that was the anatomical conditions were, built a new condition, and that's what the one new accessory pathway was created, and because of that that re-entry happens. Now second condition is that functionally defined re-entry. Re-entry also may occur in the absence of distinct anatomical defined pathway. Means here there is no accessory pathway. Without accessory pathway also the re-entry happens, right? So what is happening here? For example, alterations in cell coupling following acute myocardial infarction in dogs. This is just an example given for dog, but I'll tell you in more simple form. Suppose that there is a one ischemic condition. Because of the ischemic condition in the heart, one area in the heart is become dead, or you can say the scar formation is there in that particular area. So that area in the heart is not able to conduct the impulses. But when the impulse approaches to that particular part, right, the impulse approaches, suppose that this is the area which has been kind of dead or kind of scarred into the cardiac tissues, and the impulses comes from here. When impulse comes from here, it cannot cross through because it's not electrically responsive now. So this impulse which is coming from here, it divides here and here. It divides in two ways. Okay, so that's what, and it divides and moves on. So what is happening here? If ischemia or other electrophysiological perturbations result in an area of sufficiently slow conduction in the ventricle, impulses existing from that area may find the rest of the myocardium re-excitable, in which case fibrillation may occur. So what is happening? They are not able to cross through that area, so they diverted from there and they are started disturbing the neighboring pathways, right? And in that way they are generating additional impulses, and because of the generating additional impulses, the fibrillation condition causes. So atrial or ventricular fibrillation is an extreme example of functionally defined re-entry, right? So this is because of that scar formation, that area was not functional, and in that way the impulse conduction pathway has been diverted, and that diverted pathway has forced the or disturbs the other pathways surrounding area, and they are get enhanced or additional impulses, and that causes the fibrillation. Okay. In this setting, neither organized activation patterns nor coordinated contractile activity is present. So no coordination is there, no organized movement is there. So this diagram, I will not go in this text what is written here, but you can these two diagrams are also explaining you the both the same thing, anatomic barrier as well as the functional barrier, right? So here we can summarize it, common arrhythmias and their mechanisms. These are the three conditions what we have explained, and all the other what I am going to talk here, common arrhythmias, are coming under that only, right? So you can go through with these details. One condition I would like to share with you: some arrhythmias, notably ventricular fibrillation, are best treated not with drugs but with the direct current cardioversion, the application of a large electric current across the chest. You might have seen the supply of the current to the chest, right? So there are certain ventricular fibrillation conditions where these kind of currents reverse the condition, right? These techniques also can be used to immediately restore normal rhythm in less serious cases. Here you can see implantable cardioverter defibrillators, ICDs, right? Devices that are capable of detecting the ventricular fibrillations and automatically delivering defibrillating shocks are used increasingly in patients judged to be at high risk for ventricular fibrillation. Often drugs are used with these devices if defibrillating shocks which are painful occurs frequently. Here you can see I brought some ECG pictures for you, which gives you the different ECG status. You can see in the normal rhythm how the ECG looks like. Then if it is a premature ventricular beat, then how it looks like. And in the case of PSVT, it looks like at the stage C. Here you can find the atrial fibrillation. You can also see atrial flutter down there. Here you can find atrial flutter with atrioventricular conduction, monomorphic ventricular tachycardia, torsion de Pontes, and ventricular fibrillations. Now here I am giving you certain more classifications of these types of arrhythmias. So here we call it as an extrasystole. These are the premature beats due to abnormal automaticity or after depolarization arising from an ectopic focus. Already we have discussed about the extrasystole condition. In the atrium, if it is in the atrium, then we call it as an atrium extrasystole, right? If it is in AV node, we call it as nodal extrasystole. If it is in ventricular, we call it as ventricular extrasystole, right? If you see the QRS complex in the ECG, you will find that is broader and abnormal in shape. Same way, this is the PSVT, as I already explained you before, that it may go up to more than 200, or means around 200, 150 to 200. Atrial flutter 200 to 350, right? Atrial fibrillation, it goes 350 to up, maybe up to 550. So it's very bad condition, atrial fibrillation. Ventricular tachycardia. So ventricular tachycardia is a condition when the tachycardic condition happens because of certain problem in the ventricular area. Torsion de Pontes, already we have discussed about it. Ventricular fibrillation. This ventricular fibrillation or atrial ventricular block is due to depression of impulse conduction through the AV node and bundle of hairs, mostly due to vagal influence or ischemia. Here we have three different conditions: first degree block, second degree AV block, and third degree AV block being caused. So I think I should stop it here as the first part of the antiarrhythmic drugs, arrhythmia and antiarrhythmic drugs. I hope in this part you have got clarity in the mechanisms of the arrhythmia, as well as you can understand what the how the normal rhythm looks like and how it changes with the arrhythmic conditions. So by this understanding, you can understand better the in the next part we will discuss about the treatment of arrhythmias, and there I will explain about it. Thank you for hearing me.